Good evening, everyone, and welcome to the webinar on the theme Translating Breakthroughs from Research to Clinical Practice. It gives me great pleasure to invite our Program Director, Dr. Nikhil Pathi, Consultant Medical Oncologist from Hyderabad, to give the opening remarks. Over to you, sir.
Thank you. Good evening, everyone. A very warm welcome to today's webinar, that is Translating Breakthroughs from Research to Clinical Practice. Thank you for taking time to be here. I would like to extend my sincere thanks at the outset to IASCO and AstraZeneca for organizing and supporting this session. They have been putting tremendous efforts in bringing together academicians and clinicians to share, exchange knowledge and experience. Well, in terms of lung cancer over the past couple of decades, there has been a tremendous progress, which I would say is nothing short of remarkable. We have got better imaging technologies. We have improved ourselves in terms of mediational staging. And most importantly, we are slightly better in understanding the disease in terms of tumor biology, especially at a molecular level. Now, this has allowed us to, move beyond the conventional or the traditional HSCC staging system and inch ourselves gradually towards what is called as precision medicine, wherein our treatments are personalized to each patient's molecular subtype. However, this also brings us or, adds up to the complexity with more and more affordable, available molecular tests. We are seeing in clinic a wide range of molecularly diverse lung cancers. So with much more treatment options available, it is also slightly confusing. Now that's exactly why our discussion or our seminar topic is actually going to help us to understand how to bridge this gap from research discoveries and to apply them into the real world clinical practice. So we would be exploring questions like what molecular tests to be done, in which stage they need to be done, how can the effective treatments be sequenced or used so that we can maximize benefits for our patients. So that is what today's meeting is about. So we are equally fortunate to have with us a great panel of medical oncologists and an interventional pulmonologist, all of them trying to help us, guide through these important questions in our clinical practice. So without any further delay, let's get started. And I once again thank you all for joining us. And I hope that this particular session would be quite engaging and insightful. So with this, I think we'll now move towards the first session, which is advanced molecular profiling and personalized therapy strategies in early stage lung cancer. I request Dr. K. Meena, consultant medical oncologist at AIG Hospitals, to please help us understand this particular topic. Dr. Meena, over.
Thank you for that wonderful introduction, sir. Good evening, everyone. I'm Dr. Meena, and today I will be giving a brief overview of how we diagnose and manage lung cancer. Can I please be permitted to share my screen?
Sure, ma'am.
Are the slides visible?
Yes, ma'am.
Yes. So today, as I've told you, this is just a brief review of lung cancer, and we know that it is a significant global burden with 2 million cases diagnosed with lung cancer each year. And it is also significantly morbid. Only 1 out of 5 people are alive at 5 years after diagnosis. If we go through the Globocan data from 2022, we see that in world, lung cancer is contributing for the second most common burden. I mean, it is the second most common cancer in incidence, and it is the leading cause of cancer-related mortality. And when we look into the data of India, Lung cancer stands at 4th position in incidence and the same position in cancer-related mortality. So with such significant high burden, in what stage are they usually presenting? In Indian data, we see that nearly 50 to 60% of the patients are presenting in advanced stage, nearly 30% in stage 3 and nearly 65% in stage 4. Why is this important? Why is the initial stage of diagnosis important? We can see in this chart that the 5-year overall survival depends significantly on the stage of diagnosis. As I have mentioned in the previous slide, nearly 60% are diagnosed at later stage, at stage 4, in which the survival at 5 years is not more than 20%. In contrast, individuals who are diagnosed at a very early stage, in stage 1 or 1A, 1B, not more than 20% are having mortality. So it is an opposite picture, and that is why we need to have a very cognizance of the screening programs, and we need to diagnose these cases early for us to have the maximal benefits. The overall survival reduces with advancing stage in cancer, and that's why screening is very important. So how do we identify these population and how do we screen them? So all the individuals who have a very strong cigarette smoking history or even occupational exposure or radon exposure, we identify the individuals. We counsel them. We take an informed consent for screening. We also counsel them for smoking cessation if they are current smokers. And then a low-dose CT scan is done. And based on the findings, if nodules are found, they will be investigated accordingly. And if no nodules are found, the individual will be put on annual low-dose CT until he is no longer a candidate for definitive treatment. The NCCN guidelines agrees with this framework, where it identifies individuals with smoking history, radon exposure, occupational, or even with strong family history of lung cancer or prolonged diseases like COPD or pulmonary fibrosis as high-risk individuals, and age more than 50 years with more than 20 pack years of smoking history are included in the screening program with low-dose CT. So why is this important? A lot of cases which are diagnosed early lung cancer, they are diagnosed incidentally because they have undergone evaluation for some other reason, and then they are identified to have a lung nodule. 62% of the cases of early lung cancer are being identified in such fashion, with only 13% being identified by screening. So we have to promote this awareness and screening programs at a national level to improve this number. And even in the individuals who were detected incidentally, we have to incorporate our screening programs so that we do not miss even a benign condition, benign nodule turning malignant. We do not miss any of such cases. So incidental lung nodule management also can help increase the screening rate in early stages. And now in the diagnosis, there is another weapon that is helping the radiologist diagnose the cases early, and that is incorporation of artificial intelligence, as has been seen by many PubMed indexed journals and publications, which is emphasizing the importance of artificial intelligence in this arena. So we usually know that lung cancer patients present with symptoms like chest pain, cough, with productive sputum or blood, hoarseness of voice, loss of appetite, loss of weight. And once we have these symptoms and we have suspicion of lung cancer, they undergo imaging with chest X-ray, chest CT scan, and to know the extent of the disease and stage it, we also do PET CT and MRI of the brain to rule out CNS disease. And histopathological diagnosis is mandatory, and tissue procurement can be done by various approaches like bronchoscopy, endobronchoscopic ultrasound guided, CT guided, sputum cytology, thoracocentesis, or even mediastinoscopy and mediastenotomy. Based on once the tissue sample is obtained, we look at the histology, and now we have also evolved into molecular testing. The decision for management in lung cancer includes not only the 3 modalities of oncology, the medical, surgical, and radiation. It also includes the radiologist and pathologist, along with the pulmonologist and a palliative healthcare team. So after these multiple stages of evaluation, we come to a diagnosis, and it is very important for us to have high index of suspicion in high-risk cases, because Many of the cases with warning signs and symptoms of lung cancer are often misdiagnosed as tuberculosis. And this not only results in a delay in management, it also results in progression of the disease. So we need to have a very vigilant and watchful approach. Now coming to the topic at hand about the molecular testing. Now, how often do we see these molecular aberrations in non-small cell lung cancer? It depends on the histology. If it is adenocarcinoma, we see it in nearly 55% of the patients, and if it is squamous, we see it in about 34% of the patients. So the evolution of lung cancer diagnostic, it has moved from histology. It is no longer simply small cell or non-small cell. It has moved to a molecular diagnostic related, a driver oncogene identification, or even PD-L1 testing has been incorporated in a very early stage, because the targeted therapies and immunotherapies are no longer in the advanced stages. They have moved to the management in the neoadjuvant and adjuvant scenarios in early lung cancers. So how do we test these biomarkers? We use different techniques like IHC, PCR, FISH, or NGS. But what is important is this test be accurate, quick, simple, accessible, relatively cheap, and requiring minimal amount of tissue from which maximum information can be procured, like sufficient coverage of gene variants, and it has to have adequate sensitivity. Clinically relevant results should be found, and it also should be able to give us information that will guide us in decision making. So this has become very important. It has caused a paradigm shift because this is moving into early stages, and we are no longer just relying on chemotherapy to take care of the disease. We are also relying on targeted therapies and immunotherapies because they are proving to be more and more effective. And the response to therapies is not just guided by one mutation. We are the resistant to understand the behavior of the disease and the resistant patterns. We are no longer going to a single gene testing. Rather, we are moving towards a parallel testing using an NGS platform where multiple mutations or alterations are tested at the same time. This is helping us to understand the behavior as well as the treatment response. So obviously, this only depicts how the treatment has evolved over time, where initially it was just chemo, and then the mutations were identified and several drugs were developed to target those mutations, and how the treatment has evolved over time. These are the different clinically actionable biomarkers in NSCLC. We see EGFR mutations, which occupy a predominant portion of it, and then we have the ALK rearrangements, ROS, BRAF, NTRK, MET, RET, KRAS mutations, and we also check for PD-L1 and tumor mutational burden because they guide us in assessing the treatment response to immunotherapy. So the NCCN guidelines recommends that we establish the histology. It may be adenocarcinoma. In adenocarcinoma, it is a category 1 recommendation, but now there is consideration for molecular testing in squamous cell carcinoma also. And not just in the metastatic disease, even in the early disease, we go for biomarker testing. And in the metastatic, we have several actionable mutations for which therapies have been established, and many of them are even emerging, like high-level meta-amplification directed therapies. And even in those individuals who do not have oncogenes, based on the PD-L1 levels, we are including immunotherapy plus or minus chemotherapy. Like I have mentioned earlier, testing several mutations parallelly is beneficial over single gene testing, not only because it gives more information. Single gene testing, if one test positive, we can go for the targeted therapy. But if the test turns out negative, again, we have to test for a different gene. So it goes in a sequential pattern, causing delay in the information that we need to address it. Whereas in NGS, we get the information at the same time, and then we can plan our therapy accordingly. A brief overview about lung cancer treatment. So initially, as is our weapon, we have chemotherapy, which was initially the treatment for lung cancer, which provided a survival of about 8 to 10 months. Then came the targeted therapy, which was based on the oncogenic drivers, the EGFR, ALK, ROS, and so forth, in which even in the metastatic setting, the survival has improved from less than a year to over 3 years. FLAURA was single agent Osimertinib in first line, which showed a benefit of over 3 years. And now we have two more trials. The Mariposa, which has amivantamab and lazertinib, and we also have Flora 2, which has osimertinib plus chemotherapy, which has shown even higher benefit, a little over 4 years. So the landscape is evolving with more and more targeted therapy being incorporated along with or in place of chemotherapy, which is showing substantial benefits. And even in individuals who do not have driver mutations, we have checkpoint inhibitors like anti-PD-1, PD-L1, and anti-CTLA4, which have shown benefit of about 3 years. So this way, the targeted therapy, which is the process of precisely identifying the particular cancer target and attacking it, is getting incorporated more and more in our cancer management. So EGFR, as I have mentioned, is the most common oncogenic driver, and in Asian population, it is seen in about 50 to 50%, and this constitutes a major bulk. And to a lesser extent, we also see ALK fusions, ROS fusions, BRAF mutations, MET, HER2, and KRAS mutations. So the overall survival benefit with newer generation targeted therapies highlights the need for molecular testing. As I have mentioned, Flora, and then we have Flora 2, we have Mariposa showing substantial benefits. And even in ALK rearranged individuals, we have seen alectinib showing the benefit. Immunotherapy, as we know, boosts the body's natural defense mechanism. And in individuals who are PD-L1 positive, it is known to attack the cancer cells with great vigor. And we have, as again has been discussed earlier, based on the molecular testing, based on the mutation, we have targeted therapies. And if there is no driver mutation, based on the PD-L1 testing, we have immunotherapies. So in conclusion, implementing incidental lung nodule management with lung cancer screenings, it is a complementary method and can achieve stage shift towards earlier disease. Diagnosis will determine the specific management strategies for lung cancer cases. Biomarker testing has evolved from single gene to multiplex testing. Newer methods like NGS show immense promise for the future. Non-small cell lung cancer management is driven by molecular testing, and biomarker test results are ideally obtaining this data before decision making will help us make the best effective management in the beginning itself. Thank you for your time.
Thank you, Dr. Meena, for that nice overview. It was quite elaborate, covering all the necessary points. Moving on to the second topic for today, is Dr. Vishal available? Dr. Vishal. I guess Dr. Vishal is not connected. Then we would move on to our next topic. I would request Dr. Rachana, Associate Professor, NIMS, Medical Oncology, to deliver her talk on Osimertinib after definitive CTRT in unresectable stage 3 EGFR mutant NSCLC. That is the LARA trial. Dr. Rachana, if you are...
Yes, good evening, Dr. Nikhil. I'm there, I'm online only.
Over to you.
Yeah, thank you. Thank you for the invitation to this talk. Sophia, can you please share the screen? Sophia?
Yes, ma'am, we're just doing it.
Yeah, okay.
Ma'am, is it visible?
Yes, Sophia, I can see it now. Yeah, you can go for the presentation mode. Yeah, so I'll be discussing about Osimertinib in the localized setting, that is in the unresectable stage 3 EGFR mutant NSCLC, the LARA trial, which is mainly for this specific subset of the EGFR mutant NSCLC. Next slide, please. So we do know that there is an unmet need, especially in the unresectable stage 3 EGFR mutant NSCLC. Whatever we have in the unresectable space of stage 3 NSCLC is the consolidation with durvalumab post CCRT. That was the first drug which was shown some effect on the survivals with the additional consolidation therapy post CCRT. But in the EGFR mutant subtype, if you have seen the post hoc analysis of a Pacific trial, we see that there is not much difference in the durvalumab arm and the placebo arm in the EGFR mutant subset. This is expected because we have seen in the metastatic setting also, where EGFR mutant population was not responding to immunotherapy. So the same thing was reflected in the stage 3 setting also. Next slide. So coming to the proper study design of LAURA study, this is for the patients who have an unresectable stage 3, either 3A, 3B, 3C NSCLC with EGFR mutation, and the mutations which included were exon 19 deletion or L858R, and patients aged 18 years were included with the performance status of 0 to 1. And the randomization was 2:1 to Osimertinib 80 mg once daily, and the other control arm was the placebo arm. The stratification was done based on the concurrent CCRT or the sequential chemoradiotherapy, and with a stage 3A versus 3B, 3C, and China versus non-China was also one stratification which they have done. The primary endpoint was the progression-free survival assessed by the independent committee review, and the sequential multiple testing was done. That is, if PFS was significant, then they recycled the alpha for the overall survival, and if overall survival was significant, then they recycled alpha for the CNS PFS test. So this is the sequential statistical analysis for the results outcomes which are coming with the LAURA design. So next slide. So these are the baseline characteristics of the randomized patients between the Osimertinib arm and the placebo arm. To concentrate, we can see that stage 3C patients are slightly on the lower side, around 15% in both the arms. Majority were either 3A or 3B. And the type of chemoradiotherapy given, it was mostly concurrent chemoradiotherapy, 92% of the patients in the Osimertinib arm and 8% in the sequential arm. And the response assessment, you can see that progressive disease patients were included in the analysis. Only CR, PR, or SD patients were included for the randomization. Next slide. Coming to the primary endpoint, the progression-free survival by the independent committee review. Osimertinib has given a progression-free survival of 39.1 months compared to 5 months only in the placebo arm. You can see the wide separation of the curves and the impressive hazard ratio of 0.16 with a significant p-value. Next slide. And this is the PFS by the investigator. Again, the hazard ratios are 0.19. Very good hazard ratios for the stage 3 unresectable NSCLC setting with the Osimertinib PFS of around 36.9 months. Next slide. So, and if you see the forest plot, all the subgroups are clearly showing a benefit with the usage of Osimertinib compared to placebo. So that we can say that there is not any specific subgroup where there is no benefit. You can't say that there is no benefit with the usage of Osimertinib in this setting. Next slide. And the response rates, the overall response rate with Osimertinib was 57% compared to placebo, that is 33%. And if you see the duration of response, it was 36.9 months compared to 6.5 months. Next slide. And coming to the distant progression in the unresectable setting, if you see the number of events in the Osimertinib arm were 40%, whereas it is 86% in the placebo arm. The distant metastasis more common in the placebo arm compared to the Osimertinib arm. Next slide. And this is the site-wise new lesions, that is the distant metastasis which are occurring. As expected, brain was the most common site of progression in patients who have received placebo. In patients those on Osimertinib also, brain is still the most common site for progression, but the numbers are very less, 8% compared to 29% in the placebo arm. Next slide. This is the progression-free survival of the CNS, that is the CNS PFS. We can see the median CNS PFS was not reached in the Osimertinib arm compared to 14.9 months in the placebo arm with a hazard ratio of 0.17. All the outcomes of this trial, we have a hazard ratios of very good hazard ratios of 0.14, 0.17, 0.19, which are very significant, and the curves are widely separated from the beginning, and this is being carried on forward also. Next slide. So if we see, there was also assessed whether the patients were staged with PET-CT or not. So pre-chemoradiotherapy PET-CT also stratification was done, and they have seen if the outcomes varied for a patient who has undergone a PET-CT staging versus those who did not undergo PET-CT staging. And also for the patients with CNS metastasis at baseline, we can see while at the time of randomization, equal randomization for the patients with CNS metastasis at baseline. Let's see the outcomes. Next slide. So this is the independent committee review assessed progression-free survival by pre-chemoradiotherapy PET-CT scan, because all the patients did not undergo a PET-CT before chemoradiotherapy. So for those patients who underwent a PET-CT, osimertinib has shown a significant improvement in the median progression-free survival, hazard ratio of 0.24, and those without a PET-CT, also the hazard ratio was 0.23, 39.1 versus 5.6 months. So staging by PET-CT did not affect the outcome for patients who received osimertinib. It was beneficial compared to the placebo. Next slide. Coming to the time to distant metastasis or death, this is also assessed by the independent committee review. This is not reached with the osimertinib arm compared to 13 months with the placebo arm, with a hazard ratio again of 0.2. Next slide. This is the slide showing the cumulative incidence of distance or non-distant local progression or death. And we can see these are the number of events. So the orange lines represent the placebo arm, whereas the blue lines represent the osimertinib arm. The distant metastasis is and local progression are worse with placebo compared to osimertinib. But if you see death by any cause, both the curves at the bottom of the slide, they are both going together. This is mainly because of the crossover which was allowed from the placebo arm to osimertinib on progression. Next slide. This is again the CNS PFS by the neuroradiologist independent committee review, and we can see the CNS PFS not reached compared to 14.9 months in the placebo arm with a hazard ratio of 0.17. Next slide. And the events, again, we can see that the CNS progression events or the non-CNS progression events were more with placebo compared to the osimertinib arm. But if you see the deaths, the curves representing the deaths both by the placebo and osimertinib are going hand in hand. Next slide. So this is a summary of the time to treatment and CNS PFS, which were better with the usage of osimertinib in the post-CCRT consolidation setting compared to the placebo. Next slide. And we also have the analysis of overall survival, but the overall survival did not show a benefit. The osimertinib arm is showing an overall survival of 54 months compared to not reached with placebo. This is mainly because 81% of the patients who progressed in the placebo arm were again given osimertinib. So because of the crossover effect, we are not finding an overall survival advantage for this trial. Next slide. And moving on to the safety, any adverse events were observed in the placebo arm and also in the osimertinib arm. Grade 3 or more adverse events were seen in around 35% of the patients in the osimertinib arm. Next slide. So what are the common adverse events which are seen with the osimertinib with this radiation pneumonitis, diarrhea, rash, and paronychia? These were the common adverse events which were seen. And the grade 3 radiation pneumonitis was seen in only 2% of the patients. Majority of the toxicities were grade 1 to 2. Next slide. So to conclude, the osimertinib demonstrated a statistically significant and clinically meaningful improvement in progression-free survival with a median PFS of 39.1 months compared to 5.6 months in the placebo arm as a consolidative therapy for EGFR mutant NSCLC post-concurrent chemo-RT. And this PFS benefit was consistent across all the subgroups. Interim oral analysis showed a positive trend in favor of osimertinib despite a high crossover rate of 81%. Safety profile was as expected and manageable adverse events. So osimertinib will become the new standard of care for the patients who have unresectable stage 3 EGFR mutant NSCLC who have progressed after definitive chemotherapy. Thank you. Sorry, definitive chemoradiotherapy. Thank you.
Thank you, Dr. Rachana, for taking us through the finer details of LAURA study. Dr. Rohit, are you available?
Sure, sir. I'll do it.
Yeah, if you'd like to, take us
Yeah,
through
I'll do
the
it, sir.
next topic, reimagining CNS mutations in EGFR mutated advanced lung cancers, how treatments compare. So Dr. Rohit is consultant medical oncologist at Yashoda Hospital. And Dr. Rohit, over to you.
Thank you, sir. At the outset, I would like to thank AstraZeneca team and thank you, Dr. Nikhil, for this wonderful opportunity today. So after the two interesting talks that we have had just now, so my topic is easier. I'll just be briefly discussing on the role of Osimertinib and what it is exactly doing in CNS metastasis. So if it's okay, can someone share my slides? Right. So today we'll be just discussing on how to reimagine CNS mutations in EGFR mutant advanced lung cancers, and specifically I'll discuss what osimertinib is doing. Next slide. Can I have the next slide? Hello.
Yes.
Right, Sophia. Okay, thank you. So sorry for the small glitch. Next slide. Can we just go into the next slide? Right. If it's okay, can we just go to the next one? I think there's a small issue. So till then, I'll just start describing. So this is something which was already discussed in the first session. So as we all know that now NSCLC is broadly classified based on its molecular subtypes. And we Asians have the highest incidence of EGFR mutation, at least in our clinical practice. I think we see around 30 to 40% patients having EGFR mutant lung cancer. Next slide. So ultimately, the point to understand is with traditional therapies like probably like first generation or second generation EGFR TKS, at least towards the end of treatment, nearly around 40% of these patients ultimately end up with brain metastasis. And unfortunately, once the disease comes into the brain, traditionally the treatment options were very poor. But with the advent of third generation EGFR TKs such as osimertinib, there is a very good blood-brain barrier penetration. And hence, even though you have brain metastasis or leptomeningeal metastasis, the prognosis is slightly better. So, so ultimately, what the point to take home is that 10% of the patients in EGFR mutant at baseline, they have brain mets, but it's almost 40% towards the end of treatment. Next slide. So again, depending on the sites of metastasis, if you see, we find that the presence of brain metastasis, it portends a very poor quality of life because many of these patients, they present with recurrent seizures, they have hemiparesis, they have visual disturbances and all. Following, so presence of brain metastasis is not only portending a very poor outcome, but it also predicts a very poor quality of life. Next slide. So let us go into the advances of what is exactly happening. Next slide. So we all know that brain is a sanctuary site for invading metastatic tumor cells, specifically because it's protected by the blood-brain barrier. So most of the traditional chemotherapies and first and second generation EGFR TKs, they do not penetrate blood-brain barrier, and hence ultimately 40% of EGFR mutant lung cancers ultimately start developing brain metastasis. But with the now it is more important that we need to discover some particular drug, any particular drug which can penetrate blood-brain barrier will actually lead to a better outcome. Next slide. So this was the preclinical studies where they have demonstrated that osimertinib actually penetrates the intact blood-brain barrier. Next slide. So these are the pictures which actually show that osimertinib has a higher concentration intracranially as opposed to the traditional EGFR TKs such as gefitinib or afatinib. These are all the preclinical models. Next slide. So again, this is an animal model where osimertinib caused tumor regression specifically in EGFR mutant brain mets. This is a mouse xenograft model. Next slide. So again, when it was studied in the clinical subjects, so there was a very good penetration of osimertinib across all different areas of healthy volunteers. Next slide. Next slide. This is again the similar thing with advanced imaging. They found out that osimertinib penetrates blood-brain barrier. There is a very good intracranial distribution. So what is the importance of osimertinib is that this is an irreversible EGFR binding TK and it prolonged PFS and OS as per the FLORA data. But in fact, whenever we describe any trial of targeted therapy in lung cancers, we also look at the CNS PFS data. And osimertinib is one drug which has definitely improved the CNS PFS to a very great extent. And it has also inhibited the growth of CNS metastasis in patients with EGFR mutant non-small cell lung cancer. Next slide. So now, what is the exact efficacy? What do the trials describe? Next slide. So this is as per the FLORA data. This was a pioneer trial which put on osimertinib into the market. And as per this particular data, it was seen that majority of these patients, who's at least 20% of patients in FLORA trial, they had baseline brain metastasis. Next slide. So this was at the final analysis, what they actually found out that the median PFS in patients with EGFR mutant lung cancer with the first generation was only 10 months in the first generation, whereas it was 18.9 months in with the osimertinib. This was the primary endpoint. But what we are more interested is in the CNS full analysis set. As you can see, the median PFS, CNS PFS was only 13.9 months in the EGFR first generation arm, but it was not reached. The hazards were also significant. The response rates are higher, it was 66 as opposed to 43% with the first generation arm. Next slide. So again, this is the graphical representation of the Kaplan-Meier curves where it was seen that the median PFS has improved irrespective of whether it was a treated metastasis or untreated metastasis. Even in fact, traditional teaching was that if you have had brain mets previously, asymptomatic patient also, it was initially proposed that you go for whole brain radiation, following which you receive some sort of target therapy. But nowadays, with all these new molecules, if the patient has asymptomatic brain metastasis, you just try osimertinib and maybe you will have a very good result without resorting to any radiotherapy. So hence, this particular data has actually proved that osimertinib has reduced CNS events specifically as compared to the standard of care, which is gefitinib or erlotinib here. Next slide. So again, the same thing which I've described in the previous slide. Next slide. So this is a again summary of the intracranial PFS. It was not reached as opposed to 13.9 months. The hazards are significant. The p-value is very good. The hazard is 0.48. There is a 50% reduction, and with a very good follow-up, this has demonstrated that the CNS PFS was statistically better with osimertinib. Next slide. Again, the same thing. Next slide. So more importantly, it was seen that the subsequent progression intracranially was reduced with osimertinib as important as opposed to the first generation. So here you can see that progression in CNS was only seen in 3 patients in the osimertinib arm, whereas it was 10 patients in this first generation arm. Even with no known metastasis, you can see that 12 patients or 6% in the standard trial arm, whereas it was only 2% in the osimertinib arm. So hence, the intracranial progression is reduced even irrespective of whether the brain mets were present or not. If they were present, the PFS is increased. It delays and probably totally inhibits any intracranial progression. Next slide. Again, if you see this is what they have seen at the 3-year interval. Almost around 28% of patients receiving osimertinib were still continuing to receive treatment, as opposed to only 9% in the standard arm. Next slide. And these are some real world evidence, and they've just given case example. I'll just discuss only one case in view of the paucity of time. So next slide. So this is one case report which was published by the Japanese people. One of the earlier case reports where they have actually given rapid intracranial response to osimertinib without receiving radiotherapy. So initially it was like I've just described. So previously it was like you give radiation, probably start on gefitinib or something. But now with osimertinib, if the patient is asymptomatic, you can just start osimertinib and maybe wait and watch. Next slide. So this is one case. This is actually a case of the AstraZeneca team. Next slide. So this was a 67-year-old male, metastatic lung cancer with EGFR L858R mutation, was initially started with gefitinib and progressed, but after starting, she also had the progression was mainly in the spinal column and in the brain. After starting osimertinib, it was a very good response. So this was one of the earlier case reports which has depicted excellent role of osimertinib, specifically with pertaining to CNS metastasis. Next slide. Again, one more similar case. So gefitinib was given, they progressed intracranially, and again osimertinib was started. There was a very good response. Next slide. Next. Can we just go to the last slide? So these are multiple case examples where they tried to demonstrate that irrespective of what initial EGFR therapy you are given, suppose you have had intracranial progression, osimertinib is an excellent drug. Specifically on progression, as we all know, we do again test for probably a liquid biopsy for EGFR T790M. And in case the T790M is positive, then you can definitely start osimertinib. But if the EGFR T790M is negative, then generally we go for a combination of initial radiation followed by second-line chemotherapy. Next slide. Next. So again, multiple case examples showing that osimertinib works excellently. Next. Can we probably directly go to the last slide? Again. Right. So just back. So as per this particular, summarizing what we all know, what has been multiple times discussed, is that suppose we have now a patient of EGFR exon 19 deletion or L858R mutation, osimertinib definitely is first-line therapy. Now after the FLAURA2 data, now we can consider combination of osimertinib and chemotherapy, specifically if the patient has a heavy burden of disease, if he has intracranial metastasis. So combining both osimertinib and chemotherapy is also a very valid therapy, and probably that's something which we need to consider in the coming few days. Thank you so much. Thank you, team AstraZeneca, and thank you, Dr. Nikhil, for this wonderful opportunity. With this, I hand over the podium to again Dr. Nikhil.
Thank you, Dr. Rohit, for taking us through the science, the clinical evidence, and real-world scenarios of efficacy of osimertinib, especially in CNS. Thank you. We would next move to our next topic, that is case discussion. That is managing early stage non-small cell lung cancer.
Vishal.
Dr. Vishal is here. Dr. Vishal?
Yeah. Nikhil,
Yeah,
hi.
sure. Hi.
Shall I present in the last?
Either ways, if you are okay now or at last, that's okay.
Yeah, just give me some time. I'll
Sure.
present in the last.
All right then. So we'll now move to our next topic, that is managing early stage non-small cell lung cancer. If my esteemed panelists are here, I would request Dr. Meena, Dr. Venkateshwar,
I am here, Meena. I'm here.
Dr. Sindhu,
Yes, sir, I'm here.
Dr. Rohit,
Yes, sir, I'm here.
Dr. Annie, Dr. Vishal is here. Yes. Yes. So we'll move to a case discussion. Can we move to the next slide, please? Yeah. So disclaimer, these slides are provided by AstraZeneca, and it's a hypothetical case of a 67-year-old gentleman who was a non-smoker, was evaluated for mild cough. An initial chest X-ray done showed a small lesion in the left upper lobe. Subsequently, a CT chest was done, which reconfirmed a left apical lobe lesion. Next, please. The patient subsequently underwent a PET CT scan. So as depicted in the images here, we can see that a significantly FDG avid lesion sitting nicely in the left upper lobe with at least no clinical evidence of any mediastinal involvement is being seen. Next, please. So the PET CT report was that an intensely FDG avid lobulated soft tissue nodular lesion was seen in the left upper lobe, suggestive of primary neoplastic etiology, and a non-avid subcentimetric prevascular lymph nodes, which most likely would be reactive. Next, please. So the patient also underwent a biopsy, which was reported as adenocarcinoma of the lung. Next. So I would like to ask my panelists, what would be your further steps in terms of management for this patient, Dr. Meena?
Sir, the PET is showing a non-FDG subcentimetric prevascular lymph node, which they have opined as non-specific. But I would still like to go for a mediastinal lymph node staging. And since we are attempting curative modality in this case, I would also like to consider MRI brain for completion. And then we can plan the therapy.
Sure.
Of course, biopsy and biopsy molecular testing.
Okay. Dr. Venkateshwar?
Sir,
Yeah.
so the size of lesion hasn't been mentioned. It's likely to be around 2 to 3 centimeters from the
Maybe
images.
3 to 4 centimeters, maybe. Yeah.
Yeah, so if it's a T2 lesion, then probably I would go for an MRI. For T1 peripheral lesions, I would skip an MRI. Otherwise, rest of the investigations, I concur with Dr. Meena.
Sure. So do you routinely do a PET CT for all your lung cancer patients, or a CT is also sometimes okay for you?
I would prefer a PET CT for all my patients with lung CS.
Wherever feasible, yeah.
Yes, yes.
And mediational evaluation for this patient, what do you think?
Definitely, yes, sir. For all curable, curative intent cases, I would go for a mediastinal evaluation.
Okay. In general, the brain imaging, what are your criteria for doing a brain imaging as part of staging the evaluation?
From T2 onwards, sir. If it's a central lesion, I would do even smaller ones, but more than 3 centimeter lesions, I would do a brain MRI.
Dr. Sindhu?
I would do a MRI brain for all patients, whoever I'm treating with a curative intent. So all early lung cancers, I would do a PET CT as well as a brain MRI.
Brain MRI, okay. Dr. Rohit, in terms of IHC or molecular tests? Dr. Rohit, if he's available. Okay. Dr. Sindhu again. So additional pathological or molecular tests, what would you ask for?
So now with the evidence, current evidence, I would definitely ask for an EGFR, ALK, and a PDL1 testing. So this is like the basic minimum things which I would like. But if the patient is willing, then probably the NGS lung panel.
Sure. Next slide, please. So we have discussed the imaging tests, that is brain imaging if it's T2 and above or a node positive disease, MRI brain preferably, and wherever feasible, PET-CT as part of staging evaluation. If not, maybe a CT scan. And tissue sampling techniques, whichever is accessible. If it's a peripherally located lesion, maybe a CT or an ultrasound guided biopsy of that lesion, or if it's a centrally located lesion, maybe a bronchoscopic or EBUS guided sampling technique. Laboratory tests on the biopsy, if at all needed, minimal IHC, and as said by our panelists, EGFR, ALK, and PDL1. So one question to Dr. Meena. You're doing these individual tests or asking for an NGS directly?
Sir, if it is affordable, I would prefer an NGS, sir, because it will give more information. And even in cases which we are planning neoadjuvant therapy, immunotherapy, or adjuvant therapy, this information will not only help us understand the behavior of the disease, it will also help us understand how the response might be to therapy, which is why I would prefer a broader panel.
Sure. Even the guidelines also suggest that maybe in doing NGS is the future way forward, but at least as a bare minimum, EGFR, ALK, and PDL1 have to be done. So what is the turnaround time for NGS at your center, Dr. Meena?
Sir, it has been from a week to 10 days.
A week to 10 days. Dr. Sindhu, at your center, if you are asking for an EGFR, ALK, and PDL1, the turnaround time?
Within a week, sir.
Within a week, you will be able to get all those tests.
Yes.
Sure. Right. Next slide, please. So we have pre-treatment evaluation. We have answered this question. Yes, importance of brain staging evaluation. Okay. Next question of pathological or mediastinal lymph node or mediastinal staging in early lung cancer. So as was said earlier, this was commonly used for centrally located tumors, and it is preferable that we do it before surgery, or if the patient is planned for an upfront surgery where at least CT or a PET-CT is not showing any mediastinal nodal disease, then maybe during surgery is also acceptable. After surgery, mediastinal staging, I don't think so is appropriate. Right. So coming to the other question, the challenge in early lung cancer, if we are getting a smaller tissue sample or a biopsy. So Dr. Sindhu, how do you face this in clinical practice? Do you get to see this?
Yes, sir. It is not very common, but yes, one or two patients we definitely face this problem of not getting an adequate sample to send for further testing.
Okay.
Like majorly, I mean, liquid biopsy has some role in these patients, but like once the histopathology at least says the morphology is adenocarcinoma, then if it is not sufficient for further molecular testing, then we do a liquid biopsy.
Okay. Dr. Meena, where do you see the role of liquid biopsy for smaller lesions in lung cancer? Do you think that it's going to be specific or sensitive in terms of picking up circulating tumor DNA?
Sir, in early lung cancer where the burden of disease is low, I wouldn't want to rely on liquid biopsy if we can actually go for a normal tissue biopsy. In situations where repeatedly it has been attempted and the patient is no longer compliant or it is not feasible, then maybe I would consider, but not as a routine practice at present.
Okay, sure. Next slide, please. So summarizing all these as again enumerated by NCCN. So for peripheral lesions, which are small, that is less than 3 centimeters, no nodes on imaging, maybe we can consider pathologic mediastinal lymph node evaluation, but it is not a must. However, if there are lesions which are even peripheral, but the size being more than 3 centimeter, or if there is nodal involvement on PET-CT, then it definitely warrants pathological mediastinal lymph node evaluation. Next slide, please. Right. So this patient underwent an EUS, and luckily there were no enlarged mediastinal nodes. The patient was also medically fit, and he underwent surgery. Next, please. So the histopathology report came out as invasive adenocarcinoma, acinoid predominant type, micropapillary part constituting around 30%. The primary tumor size largest is about 2.9 centimeter, moderately differentiated. Visceral pleural invasion is also present. Margins negative. Nodes were all, one node was positive. Yes. So final pathological stage was PT2 N1. T2 maybe because of visceral pleural invasion, right? Next slide, please. Right. So in terms of biomarker testing, do you check for molecular biomarkers? Yes, we have answered that question. So we usually prefer a pre-surgical tissue or pre-treatment tissue, if possible, wherever possible, as part of diagnostic sample. Which biomarkers do you check? We also answered that question. Next, please. So the NCC and the ESMO recommendations also, helps us to treat our patients based on localized or loco-regional lung cancer based on the molecular profile they have got. So if they are EGFR mutation, classical mutations positive, whether or not it is PDL1 positive and mutation negative. So we got pathways which we are all aware and are practicing in clinic. So testing for EGFR is quite important for us. Next, please. Right. So again, Dr. Meena, so what proportion of early lung cancer patients in your practice do you see undergoing surgery?
Sir, very early stage, stage 1 and stage 2A, many of them, sir, nearly 80% can undergo upfront surgery. But in the later stages, in the stage 3, where we are going for neoadjuvant chemotherapy and then we are looking for the disease burden to come down and then go for surgery, maybe 70 to 80%.
Okay. Dr. Venkateshwar, so from which stage onwards in your clinical practice do you counsel patients regarding neoadjuvant approach?
So since we have data for this perioperative chemoimmunotherapy from stage 1B onwards, I would consider the same here in this setting as well.
In this setting also, yeah. Okay. Dr. Sindhu?
I agree with the panelists, sir, because of the indications available, so we would consider neoadjuvant therapy from stage 2 probably.
Yeah. Even the guidelines also, at least there is a level 1 evidence to counsel patients for neoadjuvant approach from stage 2 onwards. Yeah. Dr. Venkateshwar again, what percentage of patients don't undergo resection in your practice do you see?
So basically, the number of resectable cases we see are very few.
Yeah.
And among them, if I would count, I hardly have seen 3 to 4 cases per year who undergo resection in NSCLC.
Yeah.
And I would put the percentage at probably 70% because there are many factors where even the patient chooses not to undergo surgery sometimes. When they listen to the complications and all, they consider these thoracic surgeries as more complicated. We have newer surgical approaches, but they haven't been adapted in our center yet. So the patients who withdraw from surgeries are more when compared to tier 1 cities.
Dr. Sindhu, what do you think are the possible reasons for patients not undergoing surgery?
One major reason what we see in practice is elderly patient whose lung functions are not fit enough to get an anesthetic clearance. That is one area where we see the patient is not undergoing surgery. And very rarely in our setting, there are some people who have some financial issues. Apart from that, very rarely early lung cancer patients defer surgery. I mean, majority of our early lung cancer patients, they undergo surgery.
Yeah. Dr. Meena, do you routinely discuss all your cases, in a multidisciplinary tumor board, especially cases like these stage 2, stage 3 lung cancers? And what are the points for discussion in the tumor board in terms of from the surgeon's perspective, especially?
Sir, they have both operability factors and resectability factors, sir. Actually, in the operability, sometimes even the patients who have undergone neoadjuvant therapy, they do not respond very well. There is a progression in the disease, or there is infiltration or into the adjacent structures, or even invading the rib. Those have become the factors for difficulty in proceeding with surgery. And where resectability, I agree with Dr. Sindhu, the elderly who do not have adequate lung reserve and they have multiple comorbids or a poor performance status where they could not, those have become the factors for not proceeding with surgery and changing the intent.
Yeah. So as rightly enumerated by all of you, I think there are patient-related factors, certain tumor factors, and also the center level experience or the numbers they have got. All right. Next slide, please. Yes, coming to the next question on the role of radiotherapy in lung cancer. So the role of post-operative radiotherapy in early stage resected NSCLC. Dr. Sindhu, where do you see?
So,
Yeah.
post-op radiotherapy, I think it would be restricted only if there is an R1 or R2 resection. Apart from that, I don't think there is any role for post-op RT in early stage NSCLC.
Dr. Venkateshwar, any indication in any node positivity or not? Dr. Venkateshwar?
If there is a inadequate nodal dissection, then probably I would refer for RT, otherwise only in R1 resections.
Okay. So margin negativity, complete planned lymph nodal dissection, and no extracapsular extension is what has been reported as sort of complete resection, where there is no documented evidence of any post-operative radiotherapy. Dr. Meena, where do you see the role of SBRT in early stage NSCLC, or what sort of patients will receive SBRT in your clinical practice?
Sir, the patients in whom we cannot go ahead with surgery, like the factors that were enumerated earlier, the elderly or patients who have multiple comorbids who don't have adequate lung reserve, in such patients, SBRT can be used as a modality.
All right. Next slide, please. Coming to the role of neoadjuvant therapy in early stage NSCLC, yes, this has been answered earlier. Next slide, please. So this patient had stage 2 adenocarcinoma lung. Post-surgery, he underwent molecular workup, which was classic EGFR L858R mutation. So what should be the next approach? Dr. Meena, do you counsel this patient for adjuvant chemotherapy?
Yes, sir. This is a T2N1 disease node positive. Definitely, LACE trial has shown the benefit of adjuvant chemotherapy, and I would counsel this patient for the same.
Sure. Dr. Sindhu, what are your indications or criteria for suggesting chemotherapy for early stage lung cancers?
Like Dr. Meena said, according to LACE meta-analysis, for all patients who have stage 2 to 3A, we definitely give adjuvant chemotherapy. For stage 1A, we should completely avoid. And for patients with stage 1B, it is optional. I mean, few factors like more than 4 centimeters or a poorly differentiated cancer or with some lymphovascular invasion. These are the indications where we consider giving adjuvant chemotherapy for stage 1B.
Combination of softer indications, yeah.
Yes,
Yeah.
yes.
Dr. Venkateshwar, would you suggest this patient adjuvant Osimertinib?
Yes, sir.
Yeah.
Definitely, yes.
Sure.
We have already seen the ADAURA data, so
Yeah.
yes.
Next slide, please. So again, we have discussed the role of adjuvant chemotherapy for this patient, the benefit as was depicted in the LACE trial, and drug regimens. Dr. Meena, what do you usually use in practice for adjuvant chemotherapy in lung?
Cispem, this is an adenocarcinoma case, right?
Yes, yes.
Cispem, carbopem.
PEM carbo is what you're using. Okay. So anyone using cisplatin vinorelbine or
PEM-CIS, sir.
PEM?
PEM plus
Yes,
CIS.
sir.
For
Even we
adjuvant.
use PEM plus cisplatin, sir. I think adjuvant setting, there is some survival benefit with using cisplatin. So we, wherever, I mean, only in patients who cannot receive cisplatin at all, we give generally PEM-CIS only.
Yeah, sure. Next question. Next slide, please. So this is the data from the LACE meta-analysis, that is the lung adjuvant cisplatin evaluation. So it's analysis of 5 randomized trials where they have shown that, doing adjuvant chemotherapy for patients meeting the criteria, there was benefit in terms of overall survival. The 5-year OS benefit delta was about 5.4%. Next slide, please. So again, the magnitude of benefit is higher in higher stage disease, which is biologic, what we all expect. And the trial used cisplatin vinorelbine as the base chemotherapy option. Next slide, please. The role of adjuvant osimertinib, well, we have seen from the ADAURA trial. Next slide. Even after restaging these patients using the 8th edition, a significant proportion of patients ranging from stage 1B to stage 3A, with rest of the characteristics equally matched among both the arms. Next slide, please. So we can see that the trial met its primary endpoint, that is DFS, for the subgroup analysis, which was done including stage 2 to stage 3A. And also for the stage 1B included, we can see that the hazard ratio is quite impressive, 0.23 or 0.27. So there is a definite improvement in terms of disease-free survival, with the curves starting to separate as early as 1 to 2 months. Next slide, please. However, when we look at the previous data with the use of first or second generation EGFR TKI, that is the erlotinib or geftinib, so there was only DFS benefit which was seen. However, it did not really replicate in the other trials. So, Dr. Meena, why do you think the previous or the first generation adjuvant EGFR trials did not show any significant benefit while osimertinib did?
Sir, I think CNS metastasis also has a role in this, sir, because the first generation TKIs had, and it is one of the most common sites of metastasis, and these drugs did not have any penetration across the blood-brain barrier and did not offer that CNS protection. And I think that attenuated their benefit.
Dr. Venkateshwar, your thoughts?
We all know that osimertinib is more effective than the first generation TKIs. That would be one reason. And also, as Dr. Meena had mentioned, the better CNS penetration.
Right. Next slide, please. So as was said earlier, that the pattern of recurrences, especially in those patients who received adjuvant osimertinib, is also quite different, in that majority of the recurrences were local, lung or lymph nodes, and a small proportion of patients compared to placebo had failures in the CNS. So this might actually be the point or impressive point, in fact, wherein we can see that these patients who received osimertinib tend to live longer without disease. Next slide, please. So is ADAURA practice changing, Dr. Meena?
Yes, sir, definitely.
Dr. Venkateshwar?
Yes, sir.
Dr. Sindhu?
Yes, sir, beyond doubt.
Sure. Next slide, please. So that's the reason why I think it has found its way into NCCN also for all those tumors which are stage 1B, that is T2A onwards, that is more than 3 centimeter, with the classic EGFR mutations, with or without chemotherapy, there is definitely a benefit with osimertinib. One quick question to the panel. What if you find out that there are non-classical mutations in EGFR? Would you treat or would you discuss osimertinib with those patients or not? Dr. Meena?
Sir, I haven't had much experience with these patients.
Okay. So I recently had a patient who had 3 mutations in EGFR exon 20, so which was more or less unclassical. So the patient had stage 3A disease. She received chemotherapy and underwent surgery. Now I had a dilemma whether or not should I discuss osimertinib.
But I believe, at least as the guidelines are very clear in offering this only to exon 19 deletion or L858R.
Correct. So Dr. Sindhu, what do you think? Are we
No, sir. I think even I agree with Dr. Meena. I think we will restrict our indications in the adjuvant setting at least to these two I mean deletion and the L858R mutation, because we do not know whether it would benefit the patient or not. So I think it would be just extra added cost, and then
Yeah. We know that osimertinib is active in those mutations also, but we never really we don't have data for that to use in that particular indication or uncommon mutation status. So we
yes, sir,
haven't
particularly
really.
because of the early disease, I think we can avoid.
Yeah. Next slide, please. Sure. I think that's the end of case discussion. If Dr. Vishal is here.
Yeah.
Yeah,
Yeah, Nikhil, I'm here.
sure.
I can start my presentation if
Yes.
you're all.
Yes. So, panel, Dr. Vishal is interventional pulmonologist at KIMS, Secunderabad. He does a lot of EBUS guided procedures as well as mediational staging, and maybe he'll help us understand better what he does to our patients. Dr. Vishal, over to you.
Yeah. Okay. Just in addition to the slides given, I'm just adding another 7-8 slides from my side. If you're all okay, I can just, this may help a little having a better idea for your practice.
Sure. No problem, Vishal. Yeah.
Sure. So, you're able to see the slide, right?
Yes.
Yes, sir.
Is there anything coming on your screen other than the slide?
The LAURA trial insights, that is what you put up, right?
That's what you were
Yeah.
Yeah. Okay. So, thanks for the opportunity, Nikhil. So I run a busy IP unit at KIMS Hospital, Secunderabad. So our main today's topic is on EBUS staging for lung cancer, which is obviously non-metastatic, locally advanced, or until stage 3. There is a role for EBUS to have a accurate staging for your lung cancer cases. So understanding lung cancer. So basically, as you all know, it accounts for 85% lung cancers are non-small cell lung cancer, and majority of them are being locally advanced and often non-resectable. And we often need a multidisciplinary care for these cases: pulmo, onco, patho, and all your radiation, surgical, and medical. And our role is basically to have a to act to help you in the early diagnosis, not only with linear EBUS, in our practice with radial EBUS, where even CT guided biopsies are not possible in certain sizes and certain locations, and staging them, giving adequate tissue, because these days tissue is the main focus for your regular practice, and follow up how they are doing, restaging of EBUS, etc. So staging is essential for clinical decision making and treatment planning in resectable non-small cell lung cancer. To know the extent, and also if you know the extent, you know the prognosis, and to form a treatment strategy like resectability, what surgical technique, whether your neoadjuvant treatment has worked or not. Staging is what has been helpful. So we all know previously, before to EBUS, like since a decade only, the EBUS is available, almost 10 to 12 years in India. Now around 140, 150 EBUS centers are there across India. In Hyderabad, there are 10 centers. One is ours. Mediastinoscopy used to be the usual practice and for staging of EBUS, but because of the extent of invasiveness in these procedure and non-availability of the skill available. So I just want to share, recently in July, I organized a EBUS masterclass where I wanted to invite a speaker for mediastinoscopy. Literally, the speaker was telling me, I'm unable to collect any cases since he started his practice. He's a thoracic surgeon. So he called his previous mentors and all to show some cases. So that is the level of practice of mediastinoscopy in the present era after the EBUS and EUS have been introduced. VATS, of course, especially helpful in some of the cases. This slide is showing that the advanced techniques with EBUS, mediastinoscopy, the sensitivity of staging has increased compared to the radiological sensitivity for staging. Role of EBUS is a nodal staging, restaging after neoadjuvant chemotherapy, and sometimes I get referrals from Nikhil or sir that the patient recently, one patient was on Osimertinib and the patient was progressing, and then patient was not on Osimertinib, the patient was progressing. The indication was specifically for the mutation for Osimertinib. So this is that we are happy that in that case we helped to get the tissue, and probably that was sufficient for the mutation. And sampling of perihilar parenchymal masses and used as EUSB. EUSB is the same and EBUS scope. We pass it into esophagus to mimic as a EUS. So for the stations like 7, 8, 9 and adrenal, EUS is what is needed. So we only do the EUS copy if the sizes of the lymph nodes are significantly large. Sometimes we club with gastroenterologist to do the EUSP. Advantages is with EBUS, it's not less invasive definitely than media. There's no incision on the body. It's just an endoscopic procedure into the lungs, less morbidity and complications, no need for general anesthesia. There are different practices. In our center, we do a short GA with propofol and sevoflurane because the passes when we do, we want the mediastinum not to be moving so much. And we prefer that it's a patient comfort and it depends on the infrastructure. And more number of lymph node stations can be sampled. As we go through, we'll know that it can be combined with transbronchial sampling. This is very important because I would say that if the patient underwent a PET scan with a mass and there is no metastasis, irrespective of the size, periphery, and all, I think you can avoid doing CT guided, because even if you do a CT guided, you will anyway want a staging EBUS. Rather, if you send to a pulmonologist, we can do a EBUS as well as radial EBUS of the mass also. So the advantage here is, suppose there is a mass somewhere in the perihylum or a periphery of 1 centimeter, 2 centimeter, and we have a N1, N2 stations and N3 is not seen on the PET scan. So by doing, rather than doing, if that is approach even by CT guided, by doing by EBUS approach, what we do in such cases is we start with the highest N2 or N1 pass. We don't go to the mass at all. Then we, with on-site help, if the node is positive and the tissue is adequate, we don't even have to do the biopsy of the mass also. Suppose as we go from N3, N2, N1 during the procedure, all these are negative, then definitely we go to the peripheral nodule with radial endobronchial ultrasound with CAM guidance or any other, these days is navigation, phone beam CT. We do cryobiopsies also for tissue adequacy. So this is the advantage. You can diagnose as well as stage at the same time. So I think you are very familiar with this. When the PET is positive, mediastinal lymph nodes are positive, definitely you need a mediastinal staging. So it's a straight away if it's positive, multimodality treatment. If the mediastinal lymph nodes are negative, then again you ask for a VATS assisted this procedure, and then if it's positive, multimodality. But if it's mediastinal negative, then the tumor size, if it is more than 3 centimeter, you definitely request for a staging. If it is less than 3 centimeter, you directly go for surgery. So, but I heard from the talk that any lung cancer now you're preferring to. That's what, right, Nikhil? I just heard in the case discussion that you want to stage any size tumor.
Not exactly, but once we have a suspicion, then yes, we are. But
Okay,
otherwise,
even
peripherally located tumors with no mediastinal involvement on a PET, we generally don't do if it's a smaller
don't.
tumor. But if it's a bigger tumor, then maybe yes.
Yeah. So here, suppose I just want to add one more. Suppose a PET scan is not showing mediastinal lymph node sometimes, but is showing a metastasis. Definitely, suppose a brain lesion or a spine lesion for which the patient actually got a PET CT done and proved. So I would recommend, if then in that case, what we prefer is, if that is approachable by CT guided, we only do a CT guided procedure, because already metastasis has been proven. You just need the tissue. So this is the approach when some metastasis is seen, and even though the mediastinal nodes are negative. So we have two EBUS, one is a convex probe, one is a radial probe. The convex probe below is what we do for anything around the trachea and major bronchi can be accessed with the convex probe EBUS. Anything beyond the peripheral airway, up to 7th, 8th generation, even in the last 2 centimeter of the lung area, we can send this probe with a mapping, what we call them. We study the CT, like apical segment, anterior, then basal, and posterior. So we do a mapping, and we use the C-arm to go to that area. And then, of course, if time is there, I would show good cases how we approach with radial EBUS. And these are done by thin bronchoscopes, actually, like 3 bronchoscope, 4 bronchoscope, where you can pass the scopes up to 5th, 6th, 7th generation airways. So here there is a comparison between mediastinoscopy and endosonography. As you can see, the surgical staging sensitivity and negative predictive value, and the endosonographic, these are more comparable, and the sensitivity is even higher with endosonographic staging. So that's the reason why probably endosonography has been the mode of choice in the present practice. EBUS versus surgical mediastinoscopy, same thing. Here again, the sensitivity is 81 for EBUS, the mediastinoscopy is 75%, specificity is 100%. So these are all very comparable with a lot of advantages. EBUS TBNA plus EUS TBNA, combination of both is the best approach. That's right. This side speak the same. Approaching with all guidelines recommend adding EBUS and EUSB, like doing from the transesophageal. Why I will tell you in the next few minutes. That will give the better results compared to single procedure alone. But it's not always correct. If you have a diagnosis on site, you definitely don't have to do both procedures. That's why we always prefer rapid on-site evaluation. So the same thing which I was telling. And this slide compares all the techniques like conventional TBNA. Conventional TBNA is relatively obsolete now, only done at few government setups where they still didn't purchase EBUS. EBUS, what are all the accessible nodes? EUS plus EUSB, these are all the endosonographic. All the left-sided mediastinal nodes like 4L, 7 obviously, 8, 9, 2L are better accessed by EUS. EBUS can access both the paratracheal, subcarinal, 10, 11, 12. All the N1 nodes in N2, subcarinal definitely, and then the both sides of trachea, like ipsilateral mediastinal nodes like 2R, 4R, 2L, 4L, and 3P. Compared to VATS, which was mentioned in the last, it has wide range of access to unilateral nodes. Suppose you want, the disadvantage here is, suppose there is a right-sided tumor and you are doing a VATS. The problem here is you can't go to the left-sided 11L. In that case, probably you have to club both. This is one disadvantage with VATS, but if at all there is, you can give access from both sides. it has access to every possible node there. And combining EBUS plus EUS, definitely a big advantage, because 7 by both anyway, 8, 9 and all the 5, 6 stations can also be accessed by EBUS. As you can see, the specificity is good, but sensitivity is good for EBUS, EBUS plus EUS, and as well as EBUS plus EUSB FNA. Rapid onsite, there is some centers prefer, some centers don't, but we definitely do rapid onsite. It gives, I mean, for us, it's definitely because if you are doing an N2 station, both 4R as well as, suppose for a right side tumor, 4R as well as 7 are positive on the PET. We start with 7 because it's the easiest node. Sometimes it's 4R is big, we start with 4R. But the main key of these procedures these days is not diagnosis, it is the tissue adequacy. So we, with on-site help, we first do a pass from 7, send to on-site, second pass from 4R, send to on-site. In the meantime, we try to get the core biopsies. As soon as the rose comes which is positive or cellularity is more, we forget the other node and our focus will be directed completely towards the node which is having more cellularity on the rows. So we are able to give better yield, reduce the procedure time, because especially for TB sarcoid, our procedure time sometimes ends with just 2 passes. Granuloma positive, we get gene expert saline and then the procedure ends. So with the help of Rose, I finished an EBUS in 18 minutes for a patient who had a sarcoidosis. So role of pulmonology is definitely confirm histology, molecular adequacy, and coordinating with oncologists, prepare the patient for curative intent. So LAURA trial, I think you are more familiar with this trial than me. Then how pulmonologists can integrate this, push for EBUS in all suspected N2 and N3 cases, ensure molecular profiling upfront, collaborate to identify EGFR cases early, counsel patients on evolving therapeutic landscape. The key takeaways: EBUS is vital for diagnosis, staging, and molecular testing. Pulmonologists drive early decisions in stage 3 NSCLC, and molecular testing must be a routine part of workup. So I'll just show some slides for you. Is a slide visible? Sampling.
No, Vishal.
1 second. Is it visible now?
Yeah.
Sample.
Yeah.
So I just want in any lymph node which is over 5 mm can be sampled. This is what I want to tell anybody. Sometimes some nodes are small enough, the angle of puncture may be opposite to what these are only the technical details where it matters to us. And we have to remember subcentimetric and centimetric. We look for a short axis of 1 centimeter as a very good node for biopsy, but in certain cases where we get a diagnosis even with 6, 7 mm, 7 mm short axis. But any lymph node over a 5 mm short axis can be sampled by EBUS. At least 3 different stations we target in a NSCLC, an abnormal mediastinum. Suppose rose is not available, each station we have to do 3 passes. If we get a core, I'll show how a core looks. We have to have 2 passes. And stylet always we use to dislodge the debris and try to do the passes. So commonest indications, the most of the time it's a diagnostic procedure. Staging is something where the biopsy has already been done, but now we are asking for a mediastinal staging. Metastasis is 0 on the PET. Commonest thing we do is a diagnostic plus staging. As I told, the present practice is diagnosing the mass as well as, because pulmonologists are able to diagnose the peripheral tumors with this radial endobronchial ultrasound, cryobiopsies and all that. So we are diagnosing and staging in a single go. Therapeutic is very rare, like bronchogenic cysts, only few cases we have done. The pre-procedure is always, as I said, that anyway, these are the basic things which we need: CBP, PTNR. In elderly people, we ask for a cardiac evaluation also, and the fasting status is just like for a short GA: 2 hours for water, 4 hours for liquid, 6 hours for solid, and the informed consent and everything. So what are the contraindications? Anything where the patient is not fit for a short GA or anesthesia, doing EBUS under local anesthesia, I feel is definitely not recommended because it may reduce your cost. It may reduce the infrastructure needed for all these things. But the yield will get definitely affected because the patient will be coughing while the needle is in the mediastinum. And I don't recommend doing anything lesser than a deep sedation. So these are all this, as they are all short GA contraindications, you can remember all this. On ecosprin, we can do EBUS, but not on clopidogrel or anticoagulants. So as you know, these are the, are my slides visible?
Yes, Vishal.
Hello?
Yeah.
These are the stations. In this, what EBUS can do is a 2R, 2L, 3A can't be done. Prevascular, in your case, there was a prevascular node actually. That is not possible both by EBUS as well as EUS. 3P retrotracheal, 4R, 4L can be done. 5, 6 cannot be done by EBUS. This is by EUS, it can be done. Sometimes even not in EUS, if it's less smaller size. 7 can be done in both. Lower zone, 8 and 9 can be done by EUS. Hilar, these cannot be done by EUS, but only N1 nodes can be done by EBUS. So this image clearly tells you what is done by which procedure. As you can see, the black labeled things like lump tumor, 2R, 4R, 2L, 4L can be done by both. 10R, 11R, 12R, 10L, 11L, 12L can be done by EBUS alone. 7 subcarinal can be done by both. Sometimes the angulation to subcarinal is most of the times better with endobronchial ultrasound than EUS. 8, 9 lymph nodes by EUS, liver metastasis, lymph nodes, left atrial organ by EUS. Mediastinoscopy can do 1, 2, 4 and anterior 7 only. So this is how we do a staging. Like when you already have a diagnosis and you have sent for an EBUS, then we start with N3 node first, send with a rose backup. So it's a tumor is on the right side. So now first we start with N3, 11L, 10L and 4L and send the slides. If they are positive on the rows, we don't even touch N2 and N1 because on table the diagnosis is already N3. Suppose it's negative, we go for N2. In this case, it's 7 or an ipsilateral mediastinal. So after that, we go for N1. Sometimes if N2 is also negative, we definitely do N1. So this is one report. I just wanted to show how a staging EBUS we do. Here we have a right upper lobe mass with an endobronchial extension in the right upper lobe. As you can see, it's a small image there. So this is how we report. Like we have seen 11L subcentimetric, 10L, it's not seen. I mean, it's not enlarged at all. 4L is subcentimetric and central hilar structure. So it's a benign node, 0.4 4 node. So difficult to be done by EBUS. So what we have done, then we went to N2. 4R is well defined. It's an oval. Oval means it's, I will show you what are the characteristics. Heterogeneous, so it can be done. We have done, it's positive. And then N1, well defined heterogeneous, EBNA not done, as N2 station is positive. So we have reported as right upper lobe mass lesion with endobronchial extension with mediastinal lymphadenopathy with N2 station positive, mostly spread. So how are we focusing on the tissue adequacy? We are using 4 biopsy needles. The technique we also use is a cryonodal biopsy. Suppose on the rows, the tissue adequacy is less. Then we do a cryo probe into the mediastinum and take a biopsies and using elastography and even cryo for the nodular mass biopsies. So these are the size, shape, margins, echogenicity. This is what we report on a report. At least if it's negative, sometimes even with the positivity, the EBUS may have a negative answer, though with the core, everything being achieved. So some of the characteristics we have to look at to know whether that can be positive. These are endosonographic characteristics. Suppose a oval size with a oval size, distinct margins, size more than 1 centimeter, heterogeneous, no central hilum. Central hilum means it's more of a benign. Coagulation necrosis positive. These are the signs for a malignant node. The opposite is a benign node. So if only one feature was present, it's 42% metastatic. When all four were present, it's 96%. All four were absent, 96% turn out to be benign. So these are some of the techniques we use and we try to report on the EBUS report. So those can be utilized to sometimes still in your tumor board discussions. So contraindications. So some cases, as I mentioned, like this CT image where there is a perihilar tumor actually with a right-sided effusion. So here the EBUS is not just for mediastinal nodes. Here it's directly around the major airway. The tumor is around the major airway. Hence, you can use EBUS as the first modality to diagnose it. Just like in the second image also, at the 11L station, there is a hilar tumor actually. So this last image is an interesting case where there was a esophageal tumor, but the gastroenterologist could not pass into the esophagus. So through you can do a esophageal like 3P post from the posterior trachea. You can use EBUS, and I think this was published by us. And leiomyoma was the diagnosis of this tumor. So just one video where just I want to show the technique how. So the patient was put under IGEL. Under short GA, and this is the EBUS scope which I am using. Is this visible? The video is visible, Nikhil?
Yes, Vishal. Yeah.
So I was focusing on the node, and then just want to show how a pass is done. So this is the EBUS needle. There's the black one is the EBUS scope. So once we focus exactly the angle and it's nicely opposed, we punctured the node. So the stellate is used to clean the cells. And this is how the pass is done. So this is the suction. Once the pass is done, we bring out the needle, switch off the suction. Then the assistant prepares. So just want to show how the needle tissue is processed. We keep a station where all the slides, formalin, everything is placed. We push all the material onto the slide. Now the assistant is pushing the stellate again into the needle. So all the material, suppose there is a core. As I can see, I just got a core there. And if there is a core, we push it into the formalin container. For each pass, we try to make at least 2 slides and put it into the jars and send it to the rows. And every pass we send a few wet slides and one dry slide. And if there is a need for gene expert, at the end we flush everything with saline into a saline container, into a sterile container.
Yeah. Vishal, maybe if we can.
Yeah.
Yeah.
Such a large lymph node, we are, as you can see, the needle is being jabbed multiple. The more we jab, the more is the distance from capsule to capsules, then the chance of yield increases. Yeah.
Sure.
So I hope any questions on
Sure.
the staging from
Yeah.
the panel.
Thank you, Vishal, for helping us understand the process of mediational staging and the kind of work you're doing. Just a quick question from my side.
Yeah.
So, how do we minimize this? The rapid onset evaluation shows that there is malignancy or strong possibility of malignancy. And once we fix the cores and all,
Yeah.
once in a while we get to see that there is no tumor tissue in that. So it becomes really difficult for us to counsel our patients to undergo a repeat procedure. What can be done, or where do you think is the problem with that?
Though the cores are there, then you have a negative result, right? You
Yes.
are asking. Though
Yes.
the cores are there.
Yeah.
See, once we send a rose, we ask for first thing is cellularity and any lymphoid predominance on the slide. At least more than 50% of the cellularity should be lymphocytes. Then they confirm that lymphoid tissue is there. After that, we if there are atypical cells, it's fine. If it's not, then we check whether we have a core tissue. We have adequate core from that and lymphoid tissue is present. Still, the chance of having negative result is less. But if it's there still, then probably I feel we have to consider that node as negative for atypical cells. This is what I feel, because having adequate cores and lymphoid tissue, then that's the maximum that can be done. Suppose if you
That is
still have
always
a doubt,
you meant to say that is always a possibility, despite the
yeah,
imaging or the EBUS showing characteristics. Ultimately, we may not pick up
we may
the
not.
correct spot. Yeah.
So in present days, this scenario has been reduced actually. But if we have to do um, a redo procedure or during the same time, we can use a cryobiopsy as one alternative. But even cryo would target the same area where the core was taken from. In that, there is a concept called elastography. So elastography means in a large node, there are some areas which can be negative. There are some areas which can be positive. Elastography highlights which area has more stiffness. Elastography is more like um, evaluating stiffness of the node. There is a color coding where it comes predominantly green, predominantly blue. We can target those areas, but elastography for every node we do it before doing the pass. We try to see which area can be more positive. So these are some of the techniques we can add to the
Sure.
every node, which can reduce the chance. And having a detailed evaluation of the mediastinum, suppose you have failed in getting the answer from one node, definitely the PET may have the other nodes as so. One or the other node will definitely give the answer. If it's a single node and the other nodes were negative, and we are relying only on a single station with cores and lymphoid tissue, definitely we have to label that even if we have a negative. At that moment, probably that node is negative. So staging wise also, you can take it as a negative on EBUS. This is what I feel.
Thanks, Vishal, for that insightful presentation and some
Okay, Vishal,
real-time
Nikhil,
images.
we have time. Can I just take one question?
Yes, Deepak, please.
So, Vishal, when I've not usually seen a lot of pulmonologists doing a staging EBUS, most often centers do evaluation for suspected lymph nodes, but a proper staging EBUS is most often not done. But I would really congratulate you for doing a staging EBUS. Now, on a practical front, where I talk to the pulmonologist in our setup where we do lung surgeries, I ask our pathologist on why don't you do a staging EBUS? So the reason they say is, now on as a medical oncologist, most often we were trained or we were expected that if patient has got a multi-station N2, we tend to believe that these patients are not operable. But off late, with the advent of immunotherapy, most of these patients
neoadjuvant
are
form.
being considered to be operable. Now we start
Mm.
with an N3, and if N3 comes positive, I think hands down, this patient would you wouldn't be proceeding for mediastinal evaluation. But
Yeah.
if it is an N2, now you start with a 2R, and if it comes positive,
Mm.
I asked my pulmonologist, why don't you do a 4R? They say it becomes very expensive for us to change the sheet, change the needle, and again keep doing it, because you can still end up getting a false positive because your 2R is already positive. When you pass course on
Mm.
your 4R, it might come positive again. So how do you handle such situations? Because for us in
Mm.
staging mediastinum, we need to know what kind of lymph node stations were involved, because we go with neoadjuvant chemoimmune in these patients, and later, ideally, you're supposed to do
Definitely.
the mediastinal evaluation and then take them up for surgery, which is not
Got it.
practical. So we do that during VATS and we clear the mediastinum during surgery. But if it is a 2R, would a 4R, how do you do it in your practice? 2R comes
Sir,
positive. You do 4R.
definitely, once suppose these two are N2.
Yeah, 2R
If
in
you
N2.
ask me why didn't you do N1, then I have a reason why I didn't do. But
Yeah,
here I would definitely do 4 or 7 also,
yeah. But
because
again, would you change the entire apparatus? That is the point, because our pulmonologist said it's very expensive. You can't keep doing it.
no,
So,
sir, not at all. See, for
okay.
every pass, the needle is flushed with saline and air multiple times before. So one needle for one station is not at all the concept at all.
Not
So
viable.
one needle for one procedure.
Okay.
Yeah, because that using a the needle cost is 14,000, sir, 15,000. So
Okay.
to the hospital for MRP it is 18,000, but
Okay.
we have a discounted price where we adjust the pricing according to patients.
Okay.
So I would definitely go for 4 or 7, because not just for these things, there is always a tissue adequacy which may be needed later. We always keep that in mind and try to get as much tissue as possible.
Okay.
Yeah,
Makes
and as you said, no repeat PET would be anyway planned for neoadjuvant chemo, and unless you know 4R is positive on EBUS, you cannot tell the redo thing was that your neoadjuvant really worked or not.
exactly makes sense. Yeah.
Yes, sir. No, that we do, sir. We do.
Good, good. It's really impressive. Thank you,
So
Vishal.
this is the slide. I hope you can see, sir. This is the elastography slide. Can you see the slide?
Yeah.
Yeah, the blue part in the below image. That is where a more malignant tissue can be there.
Likely.
So these are some of the techniques, like having a idea of how a malignant node looks,
Yeah, targeting a
uh,
particular with
targeting a
probability.
particular
Yeah.
area, cryo, elastography, rows. These are all the techniques which club, and then we try to increase the yield of the EBUS.
Sure. Okay, sorry, Vishal, for just
Right, sir.
stopping you
Thanks.
here in
At
your
least,
paucity of time. Yeah,
yeah. We are talking now. We recently didn't meet.
sure.
Yeah.
And now I would request another dear friend of ours, Dr. Deepak, to please take on or enlighten us about his next topic, optimizing outcomes in MET-exon 14 skipping mutations. Yeah, Dr. Deepak, to you.
And I don't think my talk is as interesting as would be. But yeah, we all know the options for MET-exon 14 skipping mutation or splice variants are currently three therapies: tepotinib, capmatinib, and crizotinib. The benefit with crizotinib is modest, whereas I would say it is more or less similar with capmatinib or tepotinib. We have amivantamab showing data with improved responses in the second or later line in patients who've been initially exposed to these targeted therapies. But not much is happening in the later lines in MET-exon 14 splice variants. So, as we all know, NSCLC is the most common diagnosis, high mortality worldwide, leading cause of cancer-related deaths worldwide. And MET-exon 14 can be found in 3 to 4% patients of NSCLC. So before I dwell into this detail about MET-exon 14, MET-exon 14 is little different than the other targetable mutations that we often see. The actionable targeted mutation other than the KRAS, like we all know, KRAS is more common in smokers. The KRAS G12C is the commonest one in lung cancer. Similarly, unlike our EGFR, ALK, RET, ROS mutations, MET has some phenotypical differences. Now, this is a very interesting point because unlike your EGFR and ALK, ROS or RET mutations, which are seen in young female non-smoker, is the predominant cohort which is enriched. MET is seen in the elderly population. MET is one such kind of mutation, which is MET splice variants is one such kind of abnormality, which is seen in patients who are elderly. And another interesting point about MET is squamous cell carcinoma patients, sarcomatoid carcinoma patients have enrichment for MET exon 14 splice variants. So females with squamous cell carcinomas or sometimes even smokers also have high MET exon 14 mutations compared to EGFR, ALK and RET mutations. So it's not like our typical mutations that we see in most lung cancer patients. So that is something which I thought is very interesting for our audience, for our medical oncology audience, that we get an elderly patient and we end up doing EGFR and ALK because they are easily available PCR and IHC. We get a turnaround time which is quick. MET is something that we tend to miss in our elderly patients. Most often, patients also would not want, the attenders also would not want to waste further resources and would call it a day. But these patients are the patients where enrichment for MET is usually seen. So guidelines now recommend MET as a standard therapy, either in first line, preferably, or in the second line. The drugs, like I told, are capmatinib, tepotinib, and crizotinib, but crizotinib use has come down significantly. Now it's predominantly the capmatinib or tepotinib. Now, OS, as we all know, if a patient harbors an actionable mutation, using chemotherapy and not exposing to these targeted therapies to these patients would significantly decrease the outcomes in these patients. Like we can see here, patients who are exposed to MET inhibitors, the median overall survival is 24.6 versus 8.1 months, almost a 3-time improvement in terms of overall survival. MET, again, this is what these slides are provided by Merck. I wouldn't really agree on this slide. There was very interesting retrospective data that got published a couple of months back in JTO with regards to the use of immunotherapy in MET exon 14 skipping mutations. So, like we know, you all have to understand that mutations like ALK, mutations like ROS, mutations like EGFR and RET, these are consistently across trials. These are the 4 mutations which have shown very dismal outcomes with immunotherapy. The only immunotherapy that has shown some benefit is ivonescimab, which is a bispecific monoclonal antibody. But other than that, all the conventional immunotherapy drugs have failed to show benefit in these mutations. Now, one very characteristic thing across these 4 mutations, that is ALK, EGFR, RET, and ROS1, is they have exceptionally high response rates with EGFR or respective tyrosine kinase inhibitors, and response rates to the tune of 80 to 90%. So these tumors are highly dependent on the tyrosine kinase pathway, and inhibiting them has shown significant benefit. Mutations that fall somewhere in between, and you have an extreme mutation, which is a KRAS G12C, which has a response rates to the tune of 30 to 40%. So they don't have either very great response rates, and even the median PFS for which drugs like sotorasib or adagrasib work are not really great. So that is one extreme. In between, you have mutations like BRAF, MET exon 14. These mutations have some responses to immunotherapy, and this was proven in the recent trial that MET exon 14 splice variant patients also respond to immunotherapy. But again, the response in comparison to the responses and the duration of responses or the PFS or overall survival are higher if they are exposed to EGFR, for a MET selective inhibitors, but nevertheless they have responses better than the mutations like classical EGFR, ROS, ALK, and RET. So it is a point that you will have to remember. Not all patients can really afford treatments like capmatinib or tepotinib, but if the PD-L1 is high, such patients do respond to immunotherapy. But if they are affordable, I think hands down using MET inhibitors makes more sense. So Vision is a study which evaluated the drug tepotinib. Here, patients of more than 300 patients with MET exon skipping mutations were seen. Now, again, before I delve into the detail of MET exon skipping mutation, an ideal testing method for MET exon skipping mutation is not a DNA-based NGS. Though this is a mutation, exon 14 skipping mutation is not a fusion abnormality like the ALK, RET, NTRK abnormalities. The skipping mutations are again better identified using an RNA sequencing more than a DNA sequencing. But if your platform, your hospital, or the lab that you send does DNA sequencing, it is not that they don't identify MET exon 14, but the sensitivity increases significantly if we use an RNA-based sequencing. So here, the study was innovative, where they've also used liquid biopsy along with solid biopsy. We have the Nile study saying that if we use liquid and solid biopsy, you end up identifying more mutations. I just go into the details of it. But again, so as we can see here, even here, you can see the median age is more than 70 years. So most of the patients are elderly, 30% were Asian patients. So, like I told you, squamous is seen in around 10% of these patients. So that is another interesting fact that is seen in MET exon 14 splice variant patients. So here, patients with advanced metastatic NSCLCs were they are taken, either patients naive, treatment naive, or patients exposed to less than 2 prior lines of therapies were allowed. The primary endpoint was overall response rate. So the Nile study said that there was a 15% higher mutation detection rate with the use of a liquid-based platform along with a solid-based platform. Here it is a little slightly on the higher side, 36%, but again, a little smaller sample size. But yeah, it's important that we send liquid and solid in patients who are phenotypically strongly mutation positive. We expect that these patients will be mutation positive. It's worthwhile to send liquid biopsy if your solid biopsy comes negative, because liquid biopsy tends to account for tissue heterogeneity in patients. So in patients who are treatment naive, we can see that the overall response rate was 58.6%. Again, most BRAF inhibitors and MET inhibitors eventually have response rates of this tune. The median PFS was 15.9 months, and the median OS is somewhere around 30 months. Whereas in patients who were previously treated, response rates were slightly lesser, 49.5%. Median PFS is again slightly lesser, 11.5 months versus overall survival of 20.4 months. Intracranial activity is there with an intracranial disease control of 88.4% and a response rate of 66.7%. A month for intracranial PFS is around 20.9 months. So efficacy, again, there is good tumor shrinkage in patients, and in Asian patients, we can see the median PFS is consistently similar across the study group, but the median overall survival is higher than the rest of the world. This has been a consistent pattern for mutations like ALK, for EGFR, where the Asian population fare better than the Western population in terms of responses and durability of responses in patients. Again, similarly, higher median overalls, the PFS though remains more or less similar. The median overall survival is higher in these patients. Now, comparing geometry versus vision, again, this is a cross-trial comparison. We all know capmatinib needs to be given at a much higher dose, 4 tablets per day, 800 mg BD is the dose of capmatinib. Then 2-step dose reduction can be done with capmatinib. Tepotinib, once dose reduction. Here you get 225 milligram tablet. 2 tablets need to be taken at once. Overall response rates are more or less similar. Again, I'll just compare these trials a little later. This is match adjusted independent comparison of both these. Not an ideal way of comparing both these molecules, but again, as we can see here, capmatinib versus tepotinib. Tepotinib fares a little better. Again, this is a cross-trial comparison, and you nearly have to take it with a pinch of salt before you buy into this data. But nevertheless, tepotinib has slightly higher median overall survival and PFS compared to capmatinib. So the biggest challenge that these patients have is once they start responding, they do well for a very long time, but lymphedema sets in. And one more other problem is the creatinine falsely goes up in these patients because it inhibits a creatinine exporter called MATE1 channels, and you have to do cystatin C and other metrics to really follow up the creatinine in these patients. But conservative management, use of diuretics would help reduction of edema. So this is the only drug with once daily dosing, but again, you have to take 2 tablets while you use this treatment. So MET exon 14 splice variant patients do decently well. You can use these tablets either upfront, or if the patient has received chemotherapy in second or later lines, you would eventually introduce these agents and would probably get a similar kind of benefit. So thank you.
Dr. Deepak, just one quick question on your experience with capmatinib or tepotinib. tolerance, side effects?
Yeah, so I have nearly 4 patients on tepotinib and 2 patients on capmatinib. Biggest challenge in terms of toxicity is the fluid retention. It slowly starts accumulating after second or third cycles, but later patients have significant weight gain. I think that is the most challenging toxicity. One patient had higher creatinine, but again, later we ran the other tests which showed that the creatinine function was good and continues to take the medication. The duration of response in these patients, I've seen that most patients do well. They do well on this treatment for almost 2+ years. But that's been my experience with a very small sample size. But we have real life data coming up from CMC Vellore, which ran the phase 4 capmatinib data, and I think it was recently published also. Patients do relatively well on these treatments.
So how did you manage the edema actually? Any dose
So after
reduction?
the first patient, we used diuretics,
Yeah.
and conservative treatment, crepe bandage on the legs and all that. But from next patients, we tell them to constantly monitor their weight at least once a week and proactively use diuretics.
Sure. Thank you, Deepak, for that talk and some insights.
I think there's a question.
Yeah, if there are any more questions.
Sir, due to an emergency, Dr. Vanapratha will not be able to deliver her lecture.
Sure.
Nikhil sir, can I request you to give the closing remarks?
Yeah, sure. Well, that brings us to the end of this particular session. And I would like to thank our sponsors, AstraZeneca, for their support and this opportunity. I would also like to thank all our wonderful speakers as well as panelists for their detailed and thoughtful presentations and insights into this particular EGFR mutated non-small cell lung cancer across stages and other mutations too. We really had some great discussions and meaningful insights. And we also had our esteemed pulmonologist share his view in terms of patient management and care. And if there is any one key message that we need to take home today is to do timely and appropriate molecular testing so that we can um, personalize our treatment options available. And that is really going to make a difference in patient's life. With that note, I would like to formally close today's session and once again thank AstraZeneca and our esteemed faculty and panelists for their time and expertise, and also for the audience for your wonderful and patient listening. So wishing
Thank
you
you
all
so
a...
much, sir. So sorry to interrupt you. So we have a question in the Q&A section.
Okay.
Sir, if you can just take that up, sir.
Yeah, sure. Given the emergence of diverse resistance mechanisms after osimertinib, such as MET amplification and EGFR pathway reactivation, what practical sequencing or combination therapy approaches are most promising beyond clinical trials for EGFR mutated non-small? So definitely emergence of EGFR resistance is bound to happen. So what we are looking at is to target these resistance mechanism upfront. So like we have got the MET amplification as well as EGFR, which can be managed simultaneously. So that is the lazertinib combination which we are using, along with amivantamab. So we have also got in the pipeline other ADCs, some of which can be used to target this drop also. So these are all these agents which are in the pipeline, and we have also got some approvals where we use another combinations like chemotherapy along with amivantamab plus lazertinib. Coming to the second question, with neighboring countries in Asia rapidly advancing access to locally developed immunotherapy agents and biosimilars, how do these regional innovations and regulatory pathways influence the overall immunotherapy oncology battle in terms of affordability? So I think it is always good for our patients, though the data may be, plus minus in these areas, but at least a significant proportion of patients will be able to, access these agents and reap the benefits. So it is always welcome whenever there is a competition in terms of availability of medicines and also in terms of pricing. And we have got some decent evidence in terms of clinical activity with whatever clinical trial data we have got for these biosimilar agents available. So it is always good and encouraging. Could you shed light on the evolving clinical data and Osimertinib, the Chinese third generation EGFR's comparative position versus Osimertinib in resistant profile, CNS penetration, and patient tolerance? So I really don't have any experience on hands-on experience on Osimertinib, but I think it is an active agent as far as its efficacy is concerned from the data standpoint. Since we don't have uh, its approval or availability in India, I really can't make any uh, answer in terms of its comparison with Osimertinib.
Yeah, just to add on the last point, Nikhil, again, we have the across data that was presented recently and in the World Cancer for Lung Congress, and Osimertinib showed more or less similar PFS and overall response rate like Osimertinib. So all the third generation EGFR TKIs more or less have similar response rates, both intracranially and also extracranially. I think Osimertinib might be of an advantage for the Chinese population, but as long as it's not available in India, like Nikhil was rightly telling, it might not really add a great value for us. But the combination of Osimertinib plus chemotherapy that was used in the high risk patients having genetic abnormalities like TP53 and tumor suppressor gene abnormalities, those patients had a very good activity with Osimertinib plus chemotherapy. Probably we can do a similar study with OC and chemo in our patient population to have an answer. Yeah.
Yeah.
So thank you. Thank
So
you.
if there are no other questions, then I think we wind it up. And thank you all.
Thank you for the opportunity, Nikhil. Thank you.
Yeah. Bye. Bye-bye.